Unplugged in, pandemic challenges in Africa as the continent surpasses 1 million confirmed cases of COVID-19. Experts believe there could be many more.
There is people denying the disease. There is also stigma that make it that people hiding instead of being open and going for testing.
Having dealt with the virus Ebola, what are the lessons that can be applied to coronavirus? Plus, what some African countries are doing to rein in this deadly pandemic on the coronavirus challenge in Africa. Hello and welcome to Plugged In. I'm Greta Van Susteren, reporting from my home in Washington, D.C. In Africa, confirmed cases of COVID-19 has reached a new milestone. More than 1 million people have tested positive for coronavirus. That is a 5-fold increase in just the past 2 months. The Africa Centers for Disease Control says more than 23,000 people have died. But there is concern that insufficient testing is masking many more COVID cases. The nation of South Africa has the most cases on the continent. It has 500,000. And a study there shows a spike in unexplained deaths from early May to mid-July, raising concern that South Africa's death toll is twice as high. With Egypt, Nigeria, Ghana, and Algeria, those 5 countries account for 75% of Africa's COVID cases. Africa represents just 5% of the world's known COVID cases, but Africa's geography and the diversity of its 54 countries represents a logistical challenge for international health organizations. Dr. Michel leads the emergency response programs at the World Health Organization's regional office for Africa. I spoke to him about the challenges of helping and educating those who need help.
This is a challenge in any outbreak, is where this is one of the critical interventions for people to have some awareness about the disease that will increase also acceptance of preventive measures. If not, there is people denying the disease. There is also stigma that make it that people hiding instead of being open and going for testing when they have a suspect case. So it's a challenge, but it's better than what we experienced in the past with Ebola in Eastern Congo.
What do you do to meet that specific challenge? What can you do?
The specific challenge is mainly to implement the preventive measures. The preventive measures like hand washing or physical distancing is sometimes a challenge in some of the settings, the crowded settings around the big cities. So in this case, you need what we call enabling interventions. You need to ensure that at least you multiply the hand washing point, that you can maybe also supply some of the sanitizers, or even distribution of masks, or setting temporary structure for isolation. But all those things require resources, and that also partners like NGOs got the right resources to set up these activities that help people to comply more.
Are you finding that you have access to all the areas that you need to get access to, or some more difficult to reach where there may be outbreaks or where people may be in great need?
It is difficult in the DRC to have access to many places for different reasons. It's a huge country. The road infrastructure is not well developed. So if we take the ongoing Ebola outbreak in the western part, in the Equator provinces, sometimes we have to use the boat, to use the river to access some of the areas. So in this case, it's difficult to deploy staff safely, as well as equipment. We are using the vaccine in the current outbreak in this part. In some of the areas, it's a challenge related to security. It requires some negotiation or working with the different conventional security forces to have access to this area. So it complicates the response.
In the event that we do get a vaccine that's effective or a treatment that's very effective, is there a good medical infrastructure for distributing it in the Congo?
It is a challenge. I just take the example of Ebola, where we were using a vaccine that is kept at a minus 60 degrees. It requires a huge logistics, sometimes using helicopters and so on. So for sure, the first people that will benefit will be probably in the big cities. But all these systems have to be in place. It's one of the things that we are advising countries to work on, to start thinking ahead in terms of regulation, even authorizing a new medicines as well as a distribution mechanism.
Are there any other challenges that you or WHO is confronting, trying to deal with the problem of coronavirus, which is occurring at a time when you're also getting more Ebola cases?
There is an ongoing, for example, cholera outbreak in some of the area in DRC. We have a measles outbreak that started last year. It has stabilized a bit, but we still have quite a big number. And COVID may not help because it's reduced our access to basic services that we could have a medium-term impact. If we have a group of children that cannot be immunized now, they will be exposed in the future and become vulnerable to any vaccine-preventable disease. This even include polio as well as measles.
Has the government been good in assisting you and assisting the WHO in trying to fight cholera, measles, Ebola, and now coronavirus?
The government, they are trying their best, but they have some limitation related to the capacity in the country in terms of health workers and in terms of also financial budget to recruit more people to do so. So the willingness is there with also the new president, but capacity is low, investment is low. Is the priorities to address in addition to health are huge, that allocation to health could not be enough to overcome all these challenges that we have. Is why there is a need for continuous support, at least for the situation to stabilize. Unfortunately, COVID will a bit worsen this major gap. So the thinking is how can we help the country to recover and become more and more resilient.
For some African countries that are dependent on imports of food and manufactured goods, coronavirus is something that's also crossing the border. Botswana shares a border of nearly 2,000 kilometers with South Africa, and truck drivers hauling goods to landlocked Botswana are responsible for 80% of the country's COVID-19 cases. Plugged In's Milar Sega has more.
Trucker Wisiso Balathi used to look forward to his daily drive from his home in Botswana to pick up goods in neighboring South Africa. But since the COVID-19 pandemic, border trips for truckers like him have become a nightmare of tests, sometimes waiting 5 days for results. Balathi says conditions at border checkpoints are miserable.
It is tough. There are times when we think of quitting. Where we go to in South Africa, there are high cases of coronavirus. What we are asking for is to be treated with dignity, as we provide an essential service.
With nearly 500,000 cases of COVID in South Africa, Botswana officials say testing people who cross the border is vital. And with confirmed cases rising in Botswana, truckers, especially those coming from South Africa, are being closely monitored.
These are largely border cases, and 80% of these 50 cases were non-citizen. So it also tells a story where the threat level or the pressure of risk is based. It is at the border.
Analyst Lawrence Okeditse says the pandemic is a wake-up call for Botswana's reliance on South African goods.
This COVID thing has proven that the country is in a precarious position, particularly when you look into its dependence on South Africa. The country needs to be at a point where it now can depend on itself for, a good number of vital supplies. We import literally everything.
Government figures show South Africa accounted for nearly 3/4 of Botswana's import bill as of April this year, and truckers are among the most vulnerable. Of Botswana's 739 COVID-19 cases, more than 600 have been truck drivers who tested positive at the country's entry points. For Mkhontise Dube in Gaborone, Mil Arcega, VOA News.
Dr. Linda Mobula is a health advisor with the World Bank for the 10th Ebola outbreak in the Democratic Republic of the Congo. She is an internal medicine physician and assistant professor at Johns Hopkins University. I asked Dr. Mobula what we have learned from infectious disease outbreaks of the past and how those strategies are being used to fight coronavirus.
A really good outbreak response involves changing behavior. Outbreaks or diseases are spread by specific mode of transmission. And in this case, we think that COVID-19 is spread via respiratory droplets, and there are discussions about whether or not it's airborne. And so in order to change behavior, I think it's really, really important and critical to engage with local, trusted community leaders. I think that's probably one of the biggest lessons learned from Ebola. It wasn't until we engaged with local community leaders, pastors, traditional leaders, that we were really able to change the direction of the response.
Here in the United States, if someone's sick, we're all, frightened of them, and we're grateful to healthcare workers who care for them. On the African continent, when people get sick, are some shunned?
I think the concept of stigma is something that is, unfortunately, a concept that is international. It doesn't matter where you are. There's a lot of stigma regarding diseases, such as Ebola, such as COVID-19. And there has been stigma here in the United States as well. And I think, back to my comment about trust, I think being able to leverage or work with survivors of COVID-19 is something that's going to be important in trying to reduce that stigma. This was done quite successfully, I think, in DRC as well as in West Africa, working with survivors to have them go back to the community to encourage them to prevent transmission. So stigma is something that we really need to address globally.
Have you ever thought that the access to drugs that are available, that we don't get the supply to Africa fast enough or enough? Are they getting the sort of the short end of this?
That's a very good question. There have been multiple drugs that have been utilized in clinical trials, such as remdesivir, as you mentioned. Dexamethasone, which is a steroid, has been found to also be effective in a trial conducted in the UK. And in terms of access to drugs and a potential vaccine, I think that is a potential fact. There could be decreased access to some of these therapies because the priority could be in high-income countries like the U.S. and like the U.K. and others, that where supplies are actually directed to these countries and you have decreased access to some of these drugs in Africa. So that's definitely an issue. I think with regards to a vaccine, once it's been approved, equal distribution to some of these other countries, low and middle income countries, is going to be something that we need to look at as well to ensure that these countries do have access to drugs, to supplies and vaccines.
There is a movement here in the United States, probably not particularly large, but somewhat, of people that call themselves anti-vaxxers. They will never take a vaccine, no matter what. Have you in Africa in your work come across people who are like thinking that they will not take a vaccine, no matter how safe and effective others might think they are?
Absolutely. In fact, during the DRC Ebola outbreak, two vaccines were being used. There's a vaccine produced by Merck and a vaccine produced by Johnson & Johnson. And there were many surveys that were conducted on obtaining community perception on the vaccine. And many individuals stated that they refused to take the vaccine. They couldn't quite understand its mode of action. There are lots of rumors about the vaccine, especially during elections. And this has created a lot of issues with regards to acceptance of the vaccine. So anti-vaxxers are all over the world. And what was done to address this? As mentioned, increased community engagement, working with local health providers, increased education about the vaccine, providing more information about the vaccine, engaging with communities, I think really helped. And I think as we look at a potential COVID-19 vaccine, there will be challenges in having communities accept this. I do think that the key is going to be communicating with community leaders, with religious leaders, with communities, and understanding their fears and concerns as well is going to be extremely important.
It's not just the coronavirus, but there's sort of a lot of problems that, worldwide that are colliding on these nations.
Absolutely. I think what we learned from the 10th DRC Ebola outbreak is that you can't effectively respond to an outbreak without having water at health facilities, without having health facilities that have a very strong infrastructure, without having food that's distributed to communities. And so one of the things that we've learned is that you have to have a multi-factorial response that includes food distribution to contacts of cases. As you're doing contact tracing, we found that individuals would run away, or they would actually seek food. They would go buy food at markets. So if you're actually giving them food, you're encouraging them to stay home. You can't have a strong, effective response if health facilities don't have access to clean water. So these are things that are extremely critical. And I think this applies to COVID-19 as well.
Dr. Mobula, thank you very much for joining me.
Thank you, Greta.
Wash your hands with soap and water before you eat, after using the toilet, after touching anything many other people touch, like a seat on a public bus. Scrub thoroughly for 20 seconds. If you cannot wash your hands, use a hand sanitizer. Taking these steps can prevent not only coronavirus, but also colds and flu and other viruses.
In Kenya, education is among the many casualties of COVID-19. Due to the pandemic, schooling in Kenya is suspended until January. Public school teachers continue to receive their salaries, but those who teach at private schools are being forced to take on other jobs to survive. VOA's Lenny Ruvaga has that story from Nairobi.
26-year-old Kezia Karanja goes about preparing her beauty shop for the day. Karanja and her colleague Rebecca Atuti, both private school teachers, pooled their financial resources and begun this business 2 months ago at the onset of the nationwide lockdown in Kenya. The teachers, who both teach humanities, make an average of $10 in sales each day. However, Karanja says that due to the fact that both are on indefinite unpaid leave from their jobs, finding the money to keep their shop running is quite the challenge.
We don't have enough stock so that you can sell the products. You see, when you are starting a business, you should have enough stock so that you can sell to the customers. But you're having challenges that when someone comes for a certain product you don't have, because you don't have the money to have the stock.
In mid-March, the government suspended learning in all institutions in a bid to stem the spread of COVID-19. While public school teachers are still drawing their salaries, many private school teachers are not. Peter Ndoro, the chief executive officer at KPSA, wants the government to offer financial support to the private schools. Ndoro told VOA that about 1,400 teachers have lost their jobs as a result of the closure of schools. The rest are on unpaid leave.
During this period, what is it that will be happening? There will be no revenue coming in. But private schools closed because they wanted Kenya to be safe, heeding to the president's call that all schools should be closed. So what is it that needs to be done? These institutions need to be supported by the government.
With a workforce of around 300,000 teachers, private schools have requested a $7 million grant to pay salaries and offset mounting costs. Zack Kinuthia, the Education Chief Administrative Secretary, says the request is under consideration.
We can say that they want to be removed from a gridlock that is almost decimating them. It can be considered at higher levels and agreements can be made. There is no money. Taxes are not being collected as they used to. We are struggling to get income, but just something can be done so that we also save them.
For now, Karanja and thousands of other teachers drawn from private schools across the country are turning to alternative sources of income and vocations to support their families. Lenny Rovaga for VOA News, Nairobi.
Finding safe ways to go to school, to go to work, and on holiday will be the key to returning to social and economic normal. In South Africa, it means cleaning up so-called moving incubators that transport about 14 million commuters to and from work. VOA's Anita Powell reports from Johannesburg.
The humble minibus taxi is a lifeline for more than 70% of South Africa's workforce. But health experts worry this system is a breeding ground for coronavirus because of riders' close quarters and the high volume of passengers. A new South African nonprofit initiative, led by a businessman who is also the eldest son of President Cyril Ramaphosa, is trying to address this gap.
When we insisted as business and as South Africans, let's open this economy, by not dealing with the commute, we basically undid what was happening with lockdown. So if you deal with the transport sector, because COVID is a virus that moves through the transport sector, if you deal with that effectively, you can actually put in an artificial lockdown.
HIV researcher Dr. Jenny Pfeiffer-Coetzee, founder and director of the African Potential Foundation, says her team has come up with several solutions, ranging from simple to complex.
What we're looking at is a system very similar to what's being used in ambulances, and that is to adapt a UVC air filter that allows the airflow to be encouraged within the taxi using various fans within the filter, and air passes through the filter where it's then irradiated within a matter of seconds and is then transferred back out into the taxi to be circulated out within the taxi.
Her team is also considering an alarm system that alerts passengers to open the windows to allow fresh air to circulate, at sanitizing stations that passengers can use to clean their hands before boarding, and at a divider between the driver and passenger. That last intervention, says Ramaphosa's business partner Brad Fisher, is especially crucial. He says the government's efforts at sanitizing taxis only work up to a point.
But you can spray this rank to death. Unless you get into the taxi, where there's a closed environment, it's a capsule with whatever it is, whether they're 3 or 10 people's epidemic, that driver gets sick, and statistically, the driver's seeing 2,000 people a month, he's going to get sick.
These measures, say Ramaphosa's team, could decrease the risk of infection by up to 80%. So far, SDI has fitted out 5,000 school transport taxis and 1,000 commuter taxis at an estimated cost of about $340,000, which works out to about $60 per vehicle, much of it provided by donors.
It's been quite a journey of discovery for us non-scientists to bring all these people together with one thing in mind. We need our people to get to work safely, and we need to save lives.
Pfeiffer-Coetzee says the team is also looking at how to scale the model to fit other African countries, which use similar transport systems to move millions of people each day. Anita Powell, VOA News, Johannesburg.
Anita Powell joins us from Johannesburg, where she has been covering the coronavirus pandemic.
So we are now in month 5 of our coronavirus story here in South Africa. And right now, as I speak, I'm in the epicenter, the province of Gauteng. We're getting the fastest growing caseload in the country. And that might be because, this is home to the Pretoria-Johannesburg Metroplex, the two most arguably important cities in South Africa. And so we're seeing huge growth in cases. Today, the health minister reported 3,400 new cases of coronavirus, which brings us to about 520,000 cases across the country.
Is the city locked down?
We are in level 3 of coronavirus restrictions. We are in actually modified, adjusted level 3 of coronavirus restrictions. So the answer is partly yes, partly no. So, for example, we have a curfew of 9 p.m. to 4 a.m. We have a total ban on sale and distribution of all alcohol and tobacco products. That came back a few weeks ago when the president reintroduced that. And we have other restrictions on large gatherings. And, for example, religious services are limited to 50 people and so on and so forth. You have to get special permits if you want to go to funerals outside of the province. So it is, as the government might say, mildly restricted, but as the people might say, quite restricted.
Is the no alcohol, is that a controversy there?
Yes. Colloquially, anecdotally, South Africans are upset over this complete ban on alcohol sale and distribution that was enacted in the middle of July. So there's a lot of grumbling about it online. But the health minister and other officials in the cabinet have held a very firm line on this. And their reasoning is very interesting, and it's not without merit. It is that South Africa's public health system is overburdened by alcohol-related injuries. And without those, they can focus on the work of dealing with COVID patients instead of dealing with people with head wounds, with broken limbs, people who've been stabbed. The health minister said recently, since the alcohol ban was enacted, they've seen a dramatic decrease in stabbings. This country has the highest HIV burden in the world, with a known 6.6 million person caseload. So we are also dealing with that. And what's interesting about that, Greta, is that South African officials on the National Coronavirus Task Force, a lot of them cut their teeth on the HIV epidemic. And so they say, actually, the fact that we have such a high saturation of HIV has actually prepared us to deal with this pandemic. We've already done one pandemic. This is not our first pandemic. We can handle this one. And they've taken a lot of lessons they've learned from HIV and also from tuberculosis, which is another very serious illness that we have in high quantity here.
Is it mandatory masks where you are?
Yes, mandatory masking in public. And here in Johannesburg, and also to some extent in the other metropoles, for example, Cape Town, there's a fairly high level of adherence to the mask guidelines. In the rural areas, what I'm hearing is it's not as tightly adhered to, and that's for a number of reasons. Largely economic. People are saying, I'm already struggling enough as it is, and now you want me to go buy an extra article of clothing. And the president refuted that in a recent speech, and he said, it's cheap, you can make your own mask. But even so, what we're hearing is that there's pretty good adhesion to mask policies in the capital cities, in the metropoles, and less so in the rural areas.
Is there an indication when this lockdown, or your restrictions are going to get lifted, or are they sort of indefinite?
Greta, I would give anything for you to pose this question yourself to Cyril Ramaphosa. Nobody knows. Cyril Ramaphosa is not saying, and it's very interesting because the level 3 restrictions, which are the eased restrictions, the modified restrictions, he's given no end date for this. At first, when we had the hard lockdown, it was at first 5 weeks, then it was extended, and then we had a slightly less hard lockdown, and now we're in level 3, which has been going on since June, and there's no sign. There's no sign whatsoever. There's no indication of when it might end. There's no benchmark that anybody knows of.
That's all the time we have. Many thanks to my guests, Dr. Michael Yao, Dr. Linda Mobula, and VOA's Anita Powell. For the latest updates on COVID-19 in Africa and around the globe, please visit our website at voanews.com. And don't forget to follow me on Twitter @Greta. Thank you for being plugged in.